just automatically do the chorioretinal setting. However, if we're interested in vitreous pathology, we'll let the imager know that we like the vitreous setting. Fixation settings will also help, and once you place the patient into the machine, you want to have the image, I don't know if you can see these red lines, but you want to have the image between the red lines. If it's outside the red lines, as you can see below, the machine will consider it a blink error and not use that image. The position of the machine, again, relative to the macula and the fovea, is easy to adjust. You then adjust the focus, and the focus essentially is like adjusting the refraction. And you can look at the real-time image on the screen to adjust the focus. When the real-time image is in good focus, the OCT image will be also. The polarization is more to do with the quality of the scan. And here's an example of what the screenshot looks like. You have the real machine right there. After the talks, you want to look at it a little bit more. And here are the various protocols. Now, sometimes this gets confusing. You see all these retina protocols, and you say, which one do I choose? I can tell you what I like to use, but there are advantages to each. And sometimes we sacrifice accuracy for speed. And some of these protocols are better for patients who just can't fixate for very long. The glaucoma scans, 4 different glaucoma scans available. I'm not going to speak about that at all. We have another speaker this evening too, as well as the anterior segment scans. So this is how the screen comes up. You click on the desired protocol, the protocol appears, you click to start scan, and the scan comes up. So these are, again, the retinal scans that are available. The EMM5 is a raster scan of the macula. It's a 5 by 5 millimeter box, and this is a little different than the Stratus. Remember, the Stratus had a circular macular map. This is a square macular map because it's a raster scan. There's actually 21 scans that's done here. It takes about 1.3 seconds. They're very high resolution scans. And notice, if you can see these white lines, the white lines in this image represent the 21 scans that are done in the EMM5. There are 29,000 data points in those 21 scans. Comparatively speaking, the 6 scans from Stratus, when the Stratus macular map was based on only 768 data points. If you want to go from any of these scans, in other words, if you want to see all of them or a few of them, instead of just getting your imager or your photographer to give you a printout, you can go right to the machine, and this video will run. Now, unfortunately, it doesn't look like my video is running, but you can move the cursor into any of those scans. This is another example, actually. This is a patient who had macular hole surgery, and this is post-op day 1. And here's the real-time image. You can see the gas bubble, the reflection. It's hard to see the image. We're imaging our patients on post-op day 1 to see if the macular hole is closed. But if the patient can't fixate through the gas bubble, you can't be certain that that center image is exactly through the macula because they're not fixating well. So what we do is we do the EMM5 and we click at each point. You can see the cross lines moving, and each cross line represents these X and Y scans. And so you can scan right around the fovea and even out more into the periphery to see the retina in all different areas. So very rapidly, instead of getting a 3-dimensional image, you can get most of the important information from that scan. And here's an EMM5 of the lamellar hole. Once again, I apologize because my video is not running. So I mentioned EMM5. You can also get inner and outer retinal thickness maps if you believe they're important. Here's an example. Outer retinal thickness, inner retinal thickness. You can also do RPE elevation and internal limiting membrane elevation maps automatically in the EMM5. And this is an example of a patient with macular degeneration done on the EMM5. Full retinal thickness, and this is the RPE map showing the pigment epithelial detachment in detail. And notice The retina is thin over the pigment epithelial detachment. This is something that's being noticed now quite often, that over pigment epithelial detachment. There obviously is retinal atrophy in many cases. The initial scan that we'll do for a patient often is this 3D reference macular scan. And the 3D reference macular scan, the reason to do it initially is then the machine is then able, through the SLO image in the vessels, to do linking of the future scans so that there won't be registration errors on the future scans. So the reference scan is a 7 by 7 by 7 cube. It takes about 2.4 seconds to do, so it's twice as long as the EMM5. And you can get the four different layer maps in this scan as well. So what I do in my clinical practice is I do an EMM5 on everybody. That's my default scan. I like it because it raster scans the macula, gives most of the information that I need, but it's quick, 1.3 seconds. So even elderly patients don't have much of a problem. I also then like to do a line scan through the fovea. And the line scan through the fovea, I like to do as an oversampled image. So you can do cross scans as well. Cross scans are XY scans. I don't personally use them much at all. Some people like them. These are 6 millimeter lines. The X and Y are 8 line scans each. And you can actually place the line scans wherever you like. I like in macular disease to go through the macula, obviously. But if you want to look at peripheral retinal disease, you want to look over a nevus, you want to see if a patient with elevation in the peripheral retina, whether it's a retinal detachment or it's schisis, you can use the line scan. And you can either ask the machine to average it, or you can see the 16 scans done in the same place. So the 16 scans done in the same place is called a high definition scan, and you can see very dense scanning, but the frames are not averaged. And this is an example of that high definition scan. This is, on the contrary, the average scan. This is a single line scan, and down here, average scan, and this is a patient with pattern dystrophy. I don't know which is better, the average scan versus the HD scan. Optovue is one of the few machines that allows you to choose. I usually choose the average scan to get rid of the spectral noise, but again, if there's anyone in the room who knows from a clinical experience whether one resolution is better than the other, I'm happy to hear it. Obvious example, this is a patient in resolution of the Optovue shows a superior image. This is a stratus image in a patient with diabetes, and you can see in the Optovue, this is an oversampled image to get rid of the speckle, and you can see there's a little subretinal fluid here, which was not particularly visible in the stratus. This is an example of the cross-scan protocol. You might use that for a macular hole. And a raster scan. A raster scan you might use if you wanted to get some quick scans of the macula in a patient who really couldn't fixate very well. It's obtained in just a little over a half a second. Grid scan is similar. This might be a good scan also for a macular hole. You get scans both in the X and Y axis. The Optovue also allows you to do a radial scan, much like the Stratus macular map. So if you like the radial scan, it's available. I don't use it personally often because it's less dense than the EMM5, but of course it's quicker. It's fewer data points, only 12,000 data points than the EMM5, and it's 12 radial scans instead of 6 radial scans. And there is interpolation between the scans, so there's pathology in these areas between these scans. You will miss it with the MM6. And just to compare the MM6 to the Stratus, 768 data points versus 12,000 data points. So 3D-OCT, looking at the three-dimensional output of these machines. The nice part about the three-dimensional output is you can scroll through all the scans if you like, and you will not miss pathology that way. Accurate volumetric data is available. If you want to look at the inner surface topography, you can do that with the 3D scans. And you get what's called a rendered fundus image, which is like a black and white photograph of the retina. So this is the rendered fundus image, and this scan